Good morning, everyone. Thank you so much for being here and joining us early in the morning here. And along with you, in-person audience, we also have a virtual audience online as well. And I want to say hello to the virtual audience as well. My name is April Armstrong. I am professor and chief of dermatology at UCLA. And I am so happy to be at this meeting where I know that you've already had many fantastic days with your colleagues to get together learning. And I know today is the last day of the conference, but we're so happy that you are here with us and to enjoy this learning session. And I'm going to have my dear colleague, Dr. Andy Blauvelt, introduce himself.
Hi, everyone. My name is Dr. Andy Blauvelt. Some of you met me yesterday. I gave a session yesterday morning on atopic dermatitis. Talking today about psoriasis, my true love, I would say. Been doing psoriasis research for a long time. I'm a dermatologist. I was in academics for a long time, and then I transitioned over to clinical trials for the last 13 years and been at the center of our revolution that we've had in the biologic space. So happy to share some of my thoughts on psoriasis to you this morning. So thanks for being here.
Great. Well, we have a fantastic program ahead for you, and specifically, we're going to take a look at the role of biologic therapies as a part of the practice. How many of you, just by show of hands, feel that you are fairly comfortable with biologics? Okay, so great. So many of you are. And I know that, we've had, over the years, increased education in this area. So Andy and I, we're going to kind of give you our perspective as we go along. So here's our welcome. And I also want to thank PeerView for providing this CME educational session. And the educational grants were provided by J&J and Lilly. And please look out for important polling questions during our presentation. And for the in-room learners, please turn in your handouts to the check-in desk after the event. All right, so here is an important QR code that you may want to scan. You can scan the QR code, and then you can ask questions for us, and we'll try to address as many questions as we can at the end of the session. So if you want to take a moment and scan that, that would be great. Okay. All right, and you can also visit PeerView at peerview.com/elevatederm24. You'll be able to get access to all the slides as well as practice aids, and you can download those. And if you need that URL later, our help desk outside will be able to provide you that again in case you are eating your croissant at this time. Okay, so we have a few goals for today. First, we're going to talk about recognizing psoriasis and the impact of psoriasis on quality of life. And we're going to review some of the recent literature in this particular area. And then we're going to also talk about and understand the rationale for the selection of biologics in patients with moderate to severe plaque psoriasis. And then finally, we're going to talk about individualizing therapy, and we are going to all engage in a fun case scenario activity where you will get to be a very active part of the participation activity here. All right, so I'm going to go in and start to talk about the first part, which is talking about some of the unmet needs and opportunities for treating psoriasis. So I've been treating psoriasis patients and have been very active in psoriasis area for over 2 decades now. And I would say that there has been a tremendous development in this area. I think I went into the area at the perfect time. And I remember during residency, that's when adalimumab was being studied for psoriasis. And since then, we've really seen an advent of 12 different biologics now in the realm. And I've seen how it has changed patients' lives. And when we think about this, and Andy and I both, we do a lot of work for the National Psoriasis Foundation, and I used to, when I was younger, go out in the community and educate people about what psoriasis is. But these days, as you know, if you turn on primetime television or the television in your hotel room, it's hard to go through a night of primetime television without seeing a psoriasis commercial. So these days, I think a lot of it is distinguishing psoriasis from other diseases and making sure that we have an elevated sort of understanding on the nuances. And one of the key things of research, I would say, in the past few years, it has been surrounding patients with skin of color and recognizing and diagnosing psoriasis in these patients. And what we know in terms of the prevalence data in the US, and our group did a lot of prevalence data analysis, is that psoriasis does occur in greater proportion in Caucasians. So in the US, it's about 3.6% of Caucasians will have psoriasis as compared to about 1.5 in African Americans. And even though there is a difference in the prevalence, what we also recognize that in patients with skin of color, sometimes we may have a bit of underdiagnosis or under-recognition. In fact, when they did a poll of the clinicians, what they noted is that for people, one of the key things is that the lack of confidence in the diagnosis with regards to diagnosing psoriasis and distinguishing it from other papulosquamous disorders in patients with skin of color. So I think this group is aware that oftentimes when we are evaluating the morphology of psoriasis in patients with skin of color, that erythema, that redness component can look very different. It can look purple, or it can even look grayish in patients with deeply pigmented skin. So I think that's something that we recognize more, and now we are building as a field an image bank for that, for education. When we think about psoriasis, we all face patients who live with psoriasis who have a high disease burden. And when you look at that, psoriasis intimately affects how they do their activities. It has a profound effect on people's psychological impairment, social impact, and also impacts people's family relationship and impairment. And I will say that you have seen probably the power of you to have already transformed many patients' lives who have psoriasis. How many of you feel like you've really helped your psoriasis patients? Yeah, so a lot of you have done that. And I think that even though our encounters, our clinic visits are short, having the confidence in knowing that you are making that positive change and that you're on this journey with a patient for the long haul is really reassuring for your patients. So even if sometimes I see most of the cases tertiary, quaternary referrals to my practice of people who've tried everything. And I think the key thing for me when I see a patient like that, when I communicate to a patient like that, is that I'm here with you in the long journey and we're gonna figure out the best treatment for you. So even if it doesn't work the first time or the second time, as long as they know that you're with them for the long haul, for the long journey, I think that's what truly matters. All right, unmet needs in psoriasis. Gosh, with all these therapies, what are the unmet needs? So a bunch of people here who treat psoriasis were polled, and then there are a few things that came out. I'll just highlight a few things. We've seen patients with psoriasis who have, for example, may not have been as responsive to their biologic, and then your question is, what do we do? Do we switch them? Do we dose escalate? Do we go from class to class? So I think that's one unmet need. And then few options for highly effective oral therapies. I think we have the newer oral therapies are definitely getting there, but are we seeing highly effective biologic level oral therapies? And I think that's one area of very important development, and that we're going to see more of that in the future. Okay, and then when we take a look at patients who have moderate to severe plaque psoriasis who are persistently untreated or undertreated, we notice a few things. So when you look at this graph, for example, we are dividing these between less than 3 palms involvement, 4 to 10, and greater than 10. And then what we're seeing is that these are the treatment, the gray represent no RX treatment, and the light blue here represent topical only. So when you look at these, you can see that a lot of people, so this is an older study, are still only either getting no treatment or topical treatment only. And if you look at people who are getting oral or biologic treatment, what you'll notice is that across the different severities, for example, we have different uses of these systemic medications. One area that we oftentimes explore with our patients are the areas that what I consider high impact areas. So what are the high impact areas? So scalp, palmar-plantar disease, facial disease, and genital disease. Why that's important is that when we're looking at these high impact areas, and we can all appreciate why those areas can disproportionately affect patients' quality of life, but some payers will allow you to also provide coverage for biologics or advanced oral therapies when patients have those high impact areas. Not everyone, unfortunately, but some payers will do that. And so when we think about coverage for these patients in terms of therapies, yes, it's a little bit more straightforward if they have at least 10% body surface area, and then one of the 10% cover those special areas. However, if they only have, for example, scalp involvement, so if you count up your entire scalp BSA, that's about 7% of the BSA. And you say, darn it, 7% is not 10%, and we know the payers are looking for that 10% or greater. Well, what I do is that I put IGA score of 3, for example, moderate, because that's very important. And I put the patient has involvement of high impact disease special areas, the scalp. And then that's usually very helpful. And so that part is important to help get coverage. But the key thing is that your patients may have a small body surface area involvement, but in the high impact areas. So this graph on the left-hand side shows the prevalence of the special area. So this is the newer data here. As you can see here, about 50 to 60% of the patients would have scalp involvement these days, and genital areas around 20%. Nail, depending on the study, it goes anywhere between about 20%. Some nail study prevalence are higher than that, to about half the patients with nails. And palmar-plantar area, those are very difficult as well. So especially when they have these special areas, I really think about ways how I can get them systemic treatment so that they can have those areas addressed. Okay, psoriasis classification. I know that this is something that keeps you up at night every night. I know it keeps Andy and I up for many nights. And so when we look at how people classify psoriasis severity, and then we're going to share with you some of our kind of trials and tribulations. In the clinical trials, they typically consider moderate to severe as 10% or greater. Okay, and mild as anything less than 10%. The National Psoriasis Foundation, about a decade ago, redefined that into mild being less than 3%, and moderate between 3 to 10%, and severe being greater than 10% of body surface area. We did that because we really want to have people really understand what moderate is. But were we listened to by the payers? I don't think so. So there are different ways of defining this. And also, definition by BSA alone does not give enough consideration to other elements. For example, impact on quality of life, involvement of the special areas, as well as past treatment failures. For example, let's take a look at these photos. The one on the knee image first. So I think we all seen the phenotype of patients, right, who may have a few plaques that are very thick and difficult to treat, but they may have a small body surface area. We also see patients, I talked about the scalp involvement of this patient, who have smaller BSA perhaps, but have a tremendous impact on their quality of life. And then genital involvement, and this is something that can be very bothersome to our patients. And when I ask patients about their genital involvement, I try to normalize that first. So I start out by saying, many psoriasis patients will have psoriasis in their genital areas or in their private areas. Have you seen anything there? And they think, when my patients hear that, oh, lots of people have it. Well, if they have it, they're more likely and more forthcoming to share that with you. And when I examine that area, of course, I always ask for permission. But I think normalizing it, having them kind of give them a comfortable space to kind of bring it up is very important, because a lot of patients actually they will show you everywhere else and they have it in the genital areas, but they'll be too embarrassed to show it to you. So I try to normalize it and I phrase it in the way that I just said to make them feel comfortable in sharing this. But I think these pictures are here to show that when we're looking at this disease, that even though the area of involvement may be small, that there are other elements to take into consideration. Okay, and then here is showing how special areas, each column represent a different special area, and showing even if small areas are involved, you have the darker blue here showing a larger impact on their patient quality of life. And to end my section here, so the International Psoriasis Council have redefined moderate to severe severity, and they look at psoriasis patients into two camps: those who are candidates for topical therapies and those who are candidates for systemic therapies. And those who are candidates for systemic therapies are defined as meeting at least one of the following criteria. So BSA 10% or more, or, the keyword is or, disease involving special areas we talked about, or failure to topical therapies. Now, I think the payers may not have gotten this message yet, but we are definitely working on that as a field in order to bring good access to our patients. And with that, I'm going to give the podium to Dr. Blauvelt.
Great.
Thanks.
Thank you, April. I just wanted to highlight, so the answer for the patients that you saw the pictures at is that all of them have severe psoriasis. All of those patients, even though they have limited disease, right, 1 to 4%. And I tell the story that, I don't know, years ago now, I had a patient with quote unquote just scalp psoriasis, and it was horrible scalp psoriasis. And because she didn't have it on other areas of her body, I said, oh, you have mild psoriasis. And I almost got punched. I literally almost got punched. So the buzzword or the teaching point here is the word mild. So limited disease, we want you to say limited disease, right? Limited psoriasis can be severe and can have a huge impact on quality of life. So be very sensitive when patients have just a few areas of saying the word mild. You don't want to say that. So, oh, you have limited psoriasis, what's your impact in your life? So I just wanted to emphasize that, that we have to get away from using mild to define low BSA. All right, so as April mentioned, we have 12 different branded biologics. We have 5 different oral drugs. I'm going to talk a little bit about this big area. There's too little time to sort of go through all 17 options, right? So the most common question I get when I speak is, Dr. Blauvelt, I don't want to know about all 12 biologics. Just tell me the best one. Just what's the best one? Well, that's a hard question to answer, because when you start comparing drugs, is it short-term efficacy? Is that how you rank? Is it long-term efficacy? What about safety? How do you put safety into best drugs? And how do you put in convenience? And so this slide is just to show you that over these last 10, 15 years, as April mentioned, we've had this tremendous growth of drugs, right? And most of them have centered on the IL-23, IL-17 pathway, as shown here. So you've probably seen these types of slides for many years now. Just to talk about it a little bit, 23 I call the orchestrator, like the regulator, the person, the Wizard of Oz behind the curtain who's doing the controls, kind of dictating psoriasis, if you will, or the upstream key cytokine. More downstream is IL-17, and it's more of the fire around the wizard head, and it's creating the psoriasis at the moment in the lesion. So we know that these two molecules, single molecules, if we target them, we have great success. Much better success than we had with TNF blockers, and also, interestingly, safer. So we have better efficacy, better safety when we target these two key molecules, 23 and 17. So that's one of the main teaching points. Now, with the 12, we have tons of data. We have so much data with these biologics, right? And there's been so many review papers now. We call them systematic reviews. This one is from April, trying to put together the ranking. So you can go, I'm not going to, again, go into this in too much details, but this is one paper that tries to rank by short-term efficacy. And you see risankizumab, ixekizumab, brodalumab, and guselkumab coming out on top of this short-term efficacy ranking. And the newest drug, bimekizumab, in more recent analyses is also coming out on top. And you see the TNFs down below. And you see the oral options we have down below. So again, a kind of a main kind of teaching point, 17s and 23s are ranking high. You're in good shape if you're using one of those drugs, much higher than TNFs and oral drugs. Here's another one that I did, and the way we did this one is we asked, in the first year of therapy, how many days during the first year are patients sitting at PASI 90 or sitting at PASI 100 out of the 365 first days? And very interesting, guess what comes on top? The same 4 drugs. So another way of kind of slicing the pie and looking at efficacy, we see risankizumab, ixekizumab, brodalumab, and guselkumab coming out on top. So that's, again, the teaching point is IL-23 blockers and IL-17 blockers coming out on top in multiple meta-analyses. You're in good shape if you're using one of those drugs in terms of efficacy. Now, safety, switching, and that's all the ranking I'm going to do, but safety supports those two as well, because we know that broad immune suppressive drugs like prednisone and cyclosporin, they push the whole immune system down. We have to worry about infections and a variety of different things. And then when we had TNF blockers emerge, we saw some of that. I would say they were safer than prednisone and cyclosporin, but we did see some signs of infection, some signs of immune suppression with TNF blockers. But with the 23s and 17s, we're really narrowed on psoriatic inflammation. That slide I showed you, that pathway, is very specific for psoriatic inflammation, and I call those drugs immune modulators. So I don't like the word immune suppressant to describe a 23 or 17 blocker. We really see no signs of immune suppression when patients on our 23 or 17 blocker. So hopefully this slide helps you a little bit think about safety with the drugs that we use. All right, and then the last piece, I wanted to talk about psoriatic arthritis a little bit more. If you do nothing else, when you see a patient with psoriasis for the first time, please ask about joint pain. Everyone should be asking about joint pain. It's the number one comorbidity. The number one comorbidity. In my practice, it's up to half of the patients who have some kind of musculoskeletal complaint. If you look at the literature, it's about 30% or so is what most people say. But really, if you probe patients and ask them, many of them have morning stiffness, they have enthesitis and the heel pain, they have back pain that can be related to psoriasis. So really important. Why is it so important to ask about this? Well, because several reasons. It affects the choice of the medicine. So for example, I talked about 23s and 17 blockers, the two, I think, best classes of drugs. I prefer 17 blockers in someone with psoriatic arthritis, and I prefer 23 blockers with someone without psoriatic arthritis. So for me, it's a critical thing to ask. Many people feel the same way in that regard. So, and of course, it's not just joints, right? The other dominant thing I always mention to patients the first time is heart disease. So joint disease is the most common comorbidity, but heart disease is the comorbidity that will kill people. And of course, if you have a diabetic, a smoker, a hypertensive psoriatic, you're going to want to get them into an internist's office, right? You're going to want to proactively get them to the right place to help with the heart disease component. All right, so some cutaneous signs can more likely point you towards psoriatic arthritis. This is in literature. If patients have nail disease, scalp disease, more severe psoriasis, usually associated more with psoriatic arthritis. So if you see these things, in particular, be thinking about patients with PSA. And we know that PSA tends to come up later, right? So this is a great, great opportunity. You've heard this hopefully over the years, that dermatologists are the ones that are going to be diagnosing, I think, and recognizing PSA, because psoriasis is tending to occur first, and then psoriatic arthritis on average about 10 years after having psoriasis. Of course, PSA can happen together at the same time with psoriasis, but in general, if you're following patients over time, keep asking about joint pain, right? Don't just ask at the beginning, how are your joints? How are your joints? Make that part of your practice. And to me, it's simple questions. You don't need some fancy questionnaire or a KOL telling you, use this screening tool. Just say, do you have joint pain? Do you have any joint pain? That's the first basic question. And then heel pain is kind of interesting, trying to get at enthesitis. Back pain can be psoriatic arthritis. And then, of course, morning stiffness lasting more than 30 minutes. I think at my age, I have morning stiffness every morning, but I don't have psoriatic arthritis. You want a stiffness that lasts, right? That keeps going. It's a couple hours in the morning before these patients are loosened up. So these are very simple way to assess. All right, and then interesting data starting to emerge that we may be able to prevent the development of psoriatic arthritis with our biologic therapies. So that's an interesting topic. It's really hard to study. It's hard to get at. We don't have, I think, definitive data in this regard, but we have lots of suggestions, including these references here, that if we treat a skin-only patient with a biologic, we possibly can prevent psoriatic arthritis. And also we have hints of that with heart disease as well. I don't have a slide to show you, but the tendency, that the hints are from the literature that we can have an impact on heart disease as well by treating with biologic therapy. So really interesting stuff. So with that, we're going to end sort of the didactic portion, and now you guys have to get activated, and we're going to do a room thing and question and answer thing with your involvement. So thank you.
I just have a quick anecdote, because when I was a young resident, my rheumatology attending said, April, because I said, what is one question? What if we can just ask one question about, about patients' joints that can be predictive of PSA? He's like, okay, well, the one question you need to ask is that, do you have stiffness in the morning? I said, okay. So I remember that imprinted in my head. Then I went into the patient's room the next time. I said, wow, sir, do you have stiffness in the morning when you wake up? And the patient's like, Dr. Armstrong, don't you think that's a very personal, private question? So I said, oh, I'm sorry, So I was like, do you have stiffness in your joints when you wake up in the morning? So I just wanted to clarify that. Okay.
Important teaching point.
Yes. So let's go to some case. So Andy and I, we're going to talk about what's considered a base case, and then so we're going to discuss some of the considerations. So and then hopefully that will use as a reference when you discuss the case with your neighbor, which is the second part of this. Okay. So we're going to first talk about this base case, and you'll have some variations of the case on your table. So A female patient presents with plaques that are erythematous and scaly on many parts of her arms, legs, and scalp that have recently become bothersome. And upon examination, pitting and onycholysis of the nails are also noted. No joint pain. Okay, so when we think about this, we're going to think about a few elements: diagnosis, treatment, monitoring, how we engage our patients. So, Andy, when you think about this patient, any thoughts about the diagnosis and the prognosis?
Yeah, so I think psoriasis is an easy diagnosis. It's a clinical diagnosis. I get lots of patients from the community that are eczema versus psoriasis. For me, it's very easy. Sometime, for me, if you're having trouble in that area, demarcation of the lesions are well demarcated in psoriasis. They're not in eczema. Nail disease versus no nail disease. Eczema itches like crazy. And then the comorbidity pattern is completely different. So I think diagnosis for me is straightforward. And by the way, I never biopsy psoriasis. It's a clinical diagnosis. You don't need a biopsy to diagnose psoriasis. So it's looking, and you ask questions, and it's a simple diagnosis. So that's for diagnosis. Treatment's going to depend on probably extent. So we don't have a BSA here. But I assume, given kind of the first part, that it's going to be widespread. And so I am someone that doesn't like step therapy. I don't believe in step therapy. I don't think you need to treat everybody with a topical and then an oral and then sort of save the best to the end. That's not what I would want. I would want the best drug first. And so I've always said and taught and practiced, it doesn't matter what the disease is. It could be perioral dermatitis or whatever. I pick the best drug for my patients. So I go to the best. I don't step through. I think step through therapy too is also insurance company driven a lot of times. It's really not patient centered. It's not the best thing for patients. Let's see. And then, of course, shared decision making is an important thing for every patient, right? You don't want to ever force a therapy on someone that they're not interested in at all. Just one comment on that, though. Sometimes patients will come in saying, I want a pill. I don't like shots. I don't like needles. I have a great success record of telling that when I describe the efficacy and safety of the options, they quickly go over and say, okay, I want the shot. Because we've had, the best drugs, if you will, have been the shot therapies and not the pills. So to me, it's kind of easy to convince people to go on shots, even though they come in not wanting that. When you kind of explain how good they are, how safe they are, how convenient they are.
That's great. So the key, the good part of having two speakers is that you get somewhat of a different perspective. And I agree with most of what Dr. Blauvelt said. But unlike Dr. Blauvelt, who has morning stiffness, fortunately, I don't have morning stiffness yet. But I did want to say one thing that about the diagnosis. Sometimes the diagnosis, in majority of the patients' diagnoses are very straightforward, as Andy have said. But sometimes the diagnosis can be not straightforward. You may see patients with plaques in possibly what we consider classic areas, but then they also have involvement of the antecubital fossa, the popliteal fossa that may look eczematous, and then sometimes the presentation of psoriasis can look like it's I call this sort of a evil related step. Sibling, it could potentially, are you looking at CTCL that you're treating? So in those challenging cases, I usually would biopsy those. And if you're in doubt, it's okay. It's okay to biopsy the patients and making sure that you are doing the right thing. And the reason is because our biologic therapies are highly effective. And if it's not budging them at all, then maybe they started with psoriasis, but there could be an immune drift that they're going from a Th17 pathway to perhaps a more Th2 pathway. So I just wanted to offer that particular perspective from someone who doesn't have morning stiffness. Okay, so here's the fun part. Now it's your turn, and so the key thing here is we want you to think about that base scenario we just talked about, and then think about how would you approach and change if the patient presented with somewhat different features. So over the next 7 to 8 minutes, discuss one of the following case variants with a colleague beside you. So first of all, look around and raise your hand if you think you like your neighbor. Okay. Some of you are like, oh, I don't know. I did not know where I'm sitting could determine who I'll talk to. And so it does require some exercise, which means that some of you may have to stand up and shift over to be closer to your neighbor. The ideal situation is if you are paired in dyads, but some rows, there will be an odd number of people. So for that, you'll see ideally a dyad, and then if at the end, if the a group of 3 can be together. So if you notice on your table, there will be these handouts. And so for the table that is over there, is where you have the case variation of, there we go. So you'll have the case variation. So the blue there is this section of the room. You'll have the case variation of older patients, someone who is greater than 70 years of age. And I want you to kind of discuss how would you just in general approach older patients who have psoriasis, and then use of systemic medications there. The middle section is our woman is then 25-year-old hoping to become pregnant and breastfeeding, and what are some of the special considerations for that. Good, no one left their neighbors yet. And for this section is, what if the patient is 47-year-old female with a history of cancer in remission for 5 years? So you'll have these sheets, and they'll have the case scenario here in case you don't remember. And then so for the next 7 minutes or so, please pair up with your neighbor and talk about your approach. And then we will come together as a group and discuss that. Okay. Oh, question, yes.
Go forth and conquer.
Oh, sorry, I can't hear you. All right, so case variation 1, so that's this side of the room. So I think it's beneficial for, all of us to kind of hear the different case variations. How many of you thought you had the hardest case? No? Okay. How many here you thought you had the hardest case? Okay. And then here, hardest case? They're like, no, not hard. Excellent. Okay. So in case variation 1, our female patient is more than 70 years of age and also has a comorbidity, obesity of 33, BMI of 33. So, Andy, what do you think about the diagnosis, treatment?
Yeah. So the first thing that's not up here and we haven't discussed is access, right? So unfortunately, I think April and I don't have a magic wand for access, but this always comes up in this population because it's predominantly a Medicare population. So that's one thing that you have to think about. Medicare patient, what can I get, right? But if we kind of take that away, which is a big thing to take away, I go back to the safety slide that I put up. I'm going to probably, in an older population, try to think about drugs that have less impact or on the immune system, or maybe less impact or safer, quote unquote. And so that puts me into the 1723 category. I probably would tend to avoid TNF blockers if I could, and over 70. Avoid things like methotrexate as well. Methotrexate in older patients, you also have to worry about renal excretion, that the kidney function goes down, and methotrexate's eliminated through the kidneys, so you have that consideration. So I would be leaning towards, if I could get it, a 23 or 17 blocker. And then weight. In general, I think April would agree with this, in general, we see heavier patients harder to treat. So that is a thing in dermatology with biologic therapies. Heavier patients are harder to treat in general. We do see, though, the more highly efficacious drugs that have come out recently tend to do better in heavier people than the older biologics. So if you remember the slide I showed you in the rankings of the biologics, so the better biologic you're using, the more better chance you're going to have also in heavier patients. And then as far we have weight-based dosing a little bit, not a lot. We have, of course, there's Remicade and Infliximab, weight-based dosing, but it's not used a lot because it's IV, it's a TNF blocker. And we have a little bit of that with ustekinumab, Stelara. We have a 45 milligram dose and a 90 milligram dose. So where else do we have weight? Do we have any other weight-based drugs? I'm trying to think where we have a higher dose. Those are the main ones. So if I put it all together, maybe ustekinumab, 90 milligrams, if I could get it, safe, have that higher dose. But any of the, I think, drugs in the 2317 category that I could get, again, that was a key thing, get it, that I could get. And then the last thing, I guess, is convenience, right? If 23 blockers are dosed less often, maybe in an older patient, you would want a more convenient option. So those are the things I would think about. But.
Yeah. I think those are great. I would just add, for your Medicare patients, some of them don't have a secondary, so that can be challenging. And of our therapies right now, only one of them are not on the SAD list, the self-administered drug list, and that's todrakizumab. So those patients can possibly go through Part B, Medicare benefit Part B for those patients. And so you may want to kind of look into that for those patients. I just wanted to mention weight-based for the BMI, bimekizumab is also has a weight-based element. But yeah, otherwise I agree. Methotrexate not great. So at tertiary hospitals, we often see transfers sometimes in ICU of overdose on methotrexate, and the people who are at highest risk are the elderly. So usually I try to avoid that if I can. So agree with that. Okay.
Any thoughts, though?
Any other thoughts from there? Did that
Hear
represent most of
anyone
the
from this
points?
side have a twist or experience or have a preference in their practice? Okay.
Okay, great.
Can you get it? Is access a problem in the Medicare patients?
Between going on samples and helping them out. But we have great reps in our area that help us out with these difficult patients, and I've used it in patients with previous history of cancer as well, and it works fantastic for them.
Okay. Great.
Great,
Thank
thank you very much. And I think wonderful job, this section of the room, and I think we covered these points that age typically should not be a limiting factor in its own right. And the key thing in the elderly is polypharmacy that we need to think about, and also minimizing the AEs. Okay, everyone, so this polling is for everyone. So let's reconsider. So if you notice on the table, there are these clickers. So there should be at least one clicker for the group. Reconsider this patient, older, BMI of 33, and is this patient a good candidate for biologic therapy? Why or why not? So go ahead and you can have one of your table mates. You see that? Okay. I see an empty clicker. So please select the answer. There may not be clicker for everyone, but there's a shared clicker. So let's go ahead and enter the response there. All right, let's take a look at the response. Okay, so the vast majority of you said number 4, yes, despite age, biologics can be safe and effective in this setting. Okay, great. That's how I think we would have answered it too. Okay, I'm going to take on case variation number 2 here. So we're talking about pregnancy and breastfeeding. That's the key thing, right? I think when I think about this particular scenario, there are a lot of literature with regards to post-marketing surveillance in patients who are pregnant or breastfeeding. And for most biologics, this literature have been reassuring in terms of no significant impact on the fetal development or in breastfeeding women. The thing is that the biologics, they can be pulled across the placenta, especially during the 3rd trimester, due to them being a monoclonal antibody and have an FC portion for the majority of it. However, as we know, we have sertolizumab, which lacks the FC portion, so the drug cannot bind to these receptors for FC portion and be pulled across the placenta. And there are 2 studies, one dedicated to pregnant women, the other dedicated to breastfeeding women, that have shown the lack of the medication during pregnancy, to the fetus, impact on the fetus as well as babies that are being breastfed. This is very important because it's really almost a 2-year commitment, right? Because it's not just pregnancy, but at least and oftentimes the recommended 1 year of breastfeeding thereafter. So here is a table looking at things that are definitely contraindicated in pregnancy, and then in the middle, looking at things that are possibly safe in pregnancy, but still unknown. I still remember the time when a lot of us use cyclosporin because we have so few choices for patients, for pregnant patients. And in fact, the last MPF recommendation on this, we're talking about phototherapy first and then cyclosporin, but we're having an update on this very soon. And so these days, when we're looking at the literature, phototherapy, safe, yes, but it's hard to get a pregnant lady in to get treated for phototherapy when they have severe psoriasis. The good thing is that for most patients who are moderate to severe, who are pregnant. Pregnancy actually is a relatively immunosuppressed state. So in most cases, psoriasis actually get a little bit better. Not in all cases, but if their psoriasis is still moderate to severe, you definitely want to make sure they're comfortable, and sertolizumab has good data behind that. Okay, any other thoughts from this audience? No, did we cover it all? Okay, let's.
I just wanted to
Okay,
emphasize, go back to one thing. So April mentioned this, but I wanted to emphasize it because not everybody fully understands this. But monoclonal antibodies are IgG antibodies, and IgG, as she said, does not tend to cross the placenta in the first and second trimester. So another strategy here is to use drugs in that middle category, for example, an IL-23 blocker early in pregnancy, and it's only the last trimester where that drug is going to be crossing the placenta and potentially harming the baby. So, and you may not, and with a long-acting 23 inhibitor, you may be able to treat a dose, right? 1 or 2 doses in that first or second trimester, knock down psoriasis and not need anything, need the drug in the third trimester when it can cross the placenta. So it's another kind of little trick, I think, less worrying about that middle category in that first part of the pregnancy.
Yeah, great point. Okay, so let's take a look at this polling question. So everyone take out your clickers. And so this is asking, how would you counsel this patient on treating psoriasis during pregnancy and breastfeeding? So please take a look. All right, so, okay, excellent. I thought one was kind of reasonable to try to, achieve complete clearance because oftentimes, these drugs actually, when they're off, they're actually, remain in, so maybe both 1 and 5, but okay. All right, the last case variation, we'll go over that quickly, is 47-year-old woman with a history of cancer in remission greater than 5 years. The question was asked about what type of cancer we thought made it possibly solid organ malignancy, such as breast cancer. And so any thoughts, Andy, on that?
Yeah, so this is a tough one. So for me, you really have to do shared decision-making with your former cancer patients or active cancer patients. And it's really a discussion, right? You have to know where they're at with their cancer, what the likelihood of recurrence. You have to know where they're at with their chemotherapy or their immunotherapy. You really have to talk to them about where they're at and then talk to them about the impact of the psoriasis and how aggressive they want to be and so forth. So I think the assumption here is that, in the case at least, is that the cancer is relatively calm, they're not on chemo or immunotherapy, they're quote-unquote stable from the cancer point of view, and their psoriasis is bad. So I think that in that setting, I personally prefer IL-23 blockers with IL-17 blockers as an alternative because there really is no cancer signal, if you will, in the long-term data we have with those two classes of drugs. TNF blockers have a label warning for leukemia and lymphoma. There's not much data as far as TNF blockers hurting solid malignancies, which is a good thing. But I do think those drugs are going to be a little bit more immunosuppressive, as I showed it again in that one slide. So I would tend to want to go towards that end of the spectrum again. But the key teaching point for me is shared decision making, the discussion,
Yes.
Because you just go in your head, like you have them on a psoriasis biologic and their cancer comes back. What's that conversation going to be like? Like, do they know that, even though there's no literature on 23s and 17s causing cancer to come back, it could come back, and how would they feel and how would they deal with that? So it's it's definitely, the conversation is really important in this type of patient.
Yes. So I tell my patients that right now there's no data suggesting that the biologics, especially in IL-17 and IL-23, influencing the natural course of your cancer. And so it doesn't seem to have an impact. So your cancer, can it come back? Possibly, based on its natural course. Can it not come back? Possibly as well. But what we know is that it may not have a direct impact. Now, patient selection is key because you want to make sure that you are initiating on a patient who understand that, and if they come with their family member, the family member understands that as well. And you want to then write to the oncologist in the medical record, not in an email, but in the medical record, say, I'm thinking about starting this patient on this, what do you think? And then get the oncologist's blessing in the medical record. Because I've been on cases where I testified for the derm who later got liability about this. So patient selection is the key, actually. And also, if they come with a family member, they all need to be on the same page because and then show them you are trying to help them, right? That you want them to have a good quality of life. So that's everything we could do to minimize the risk. We do want to help them. We can't practice like, oh my gosh, am I going to get sued if the patient gets cancer later on? We can't practice like that, but you do want to minimize the risk as much as possible. Okay, all right. So I think we touched upon all these important points and the last chance to vote here. So let's take a look at this. In the patient with history of cancer, go ahead and select your answer choice here. All right, let's take a look. Yeah, this is a tough one. So I think a lot of it has to do with, patient selection, as we talked about. So, but thank you all for engaging in this. And I think we touched upon many different topics today. And unfortunately, time flies when you're having fun. I do want to thank everyone who have submitted the Q&A. If you are around as an in-person audience, we will be here for a few minutes to answer the questions, but we also don't want to hold up the session for you to go to the next session. So I want to thank everyone for being part of our session this morning, and I also want to thank the virtual audience as well. Have a great rest of the day.